How's it going? I'm Alex Arnold, and I'm going to start with what is electrocardiography. Electrocardiography, also known as ECG, is a transthoracic, meaning across the thoracic cavity or across the chest, which is an interpretation of the electrical activity of the heart over a period of time, as detected by electrodes attached to the outer surface of the skin and recorded by a device external to the body. The recording produced is a non-invasive procedure that is termed electrocardiography, or electrocardiogram. It is used to measure the rate and regularity of heartbeats, as well as the size and position of the chambers, the presence of any damage to the heart, and the effects of drugs or devices used to regulate the heart, such as a pacemaker. The ECG device detects and amplifies tiny electrical charges on the skin that are caused by the heart, or when the heart depolarizes, which happens every heartbeat. During each heartbeat, a healthy heart has an orderly progression of a wave of depolarization that is triggered by the cells in the sinoatrial node, spreads out through the atrium, passes through the atrioventricular node, and then spreads all over the ventricles. This is then detected as tiny rises and falls in the voltage between two electrodes that are placed on either side of the heart, which is displayed as a wavy line either on a screen or on a piece of paper. This display indicates the overall rhythm of the heart and weaknesses in different parts of the heart's muscle. Next, I'm going to explain Enthoven's triangle. William Enthoven is a pioneer of electrocardiography, creating the basic system of measure for electrical activity of the heart. The original layout is still used today, which is a basic 3-lead electrocardiogram, consisting of placing electrodes at the right arm, the left arm, and the left leg, varying the placement of positive, negative, and ground wires. The general idea of the heart's electrical activity can be observed. The term lead refers to the view of the heart's activity that you are looking at that particular time. Next, I'm going to direct your attention to a picture so I can explain this further. Lead 1 and lead 2 and lead 3 are all dipole, which means they are a pair of equally and oppositely charged poles separated by a particular distance. Lead 1 has its negative electrode at the right arm, which is the white electrode, and the positive electrode at the left arm, the black electrode. Lead 2 has its negative electrode at the right arm, the white electrode, and the positive electrode at the left leg, which is the red electrode. The third and last lead has its negative electrode at the left arm, which is the black electrode, and the positive electrode at the left leg, which is the red electrode. This all creates an upside down triangle, also known as Enthoven's triangle.
Now that you know what an ECG is and kind of how it works, now I'm going to explain how to apply a 12-lead ECG. Now compared to Enthoven's triangle that Alex just explained, the 12-lead ECG provides a more in-depth analysis of heart activity. Whereas Enthoven's triangle can only record heart rate and rhythm, the 12-lead ECG can record and help diagnose a wide variety of cardiac conditions. Now, when someone hears 12-lead ECG, they assume that 12 electrodes are going to be used. However, that's not the case. Only 10 are going to be used. The reason for this is because the term lead actually means a particular view of the heart. Now, so a 12-lead ECG means that the heart is going to be viewed from 12 different views. So think of a lead as a picture, and the 10 electrodes used in a 12-lead ECG is going to provide us with 12 pictures of the heart. Alright, now I'm going to show you how to apply a 12-lead ECG to a patient. First, we're going to start by informing the patient to lie in a supine position as he is now, with the shirt off. This gives us easy access to his skin where the electrodes are going to be placed. Then we're going to inform him to remove all electrical devices, such as cell phones, pagers, things of that nature, because these can be picked up by the ECG monitor, and we want the only electrical activity to be picked up from the heart, and that's all, no external devices. Now we're going to start by applying the limb leads, the 4 limb leads. Now these differ from exercise and resting. Today I'm going to show you where to apply them if you are going to perform an exercise test. But also I'm going to note where you would place them if they were during rest. First I'm going to explain where you're going to place them during rest. during rest, you're going to place one on the right arm, one on the left arm. On the arms, it's going to be in between the shoulder and the wrist, so anywhere in between there. Same on the left arm. Now for the legs, you could put it in between the torso and the ankles, so you could put it on the thigh. That's for resting. Now for exercise, we typically do it more towards the midline. The reason for that is because if it's placed on the limbs and the extremities where during rest, as it is during rest, then a lot of artifact, because they'll be moving those limbs during exercise, which will cause error in the ECG recording. Now I'm going to apply the 4 exercise limb leads. The right limb lead is going to place in the upper right aspect of the chest and shoulder region, just below the distal end of the right clavicle, so in the fossa, so just about right here. Now the left one is going to be placed in the same area except on the left side. Now the lower limb leads are going to be placed in the lower right anterior lateral surface of the external oblique muscle, just above the iliac crest at the level of the navel on the anterior surface of the abdomen. So just above the iliac crest and the level of the navel. And the same thing is going to be for the right side. Now I'm going to mark the 6 chest leads. And now these are the same no matter if it's during exercise or during rest, they are always the same. Now these 6 leads are named V1 through V6. I'm going to start off by marking V1. Now V1 is on the patient's right side of their sternum, my left side. So you're going to find their sternum, and you're going to find their clavicle. And then you're going to go to the 4th intercostal space. So you're going to palpate that. Now key to this is you don't want to just eye it up and just pick, because the where you place these is essential to the recordings being correct. So you can't just eye it up and place them wherever you want. You need to make sure you place them in the right anatomical position. Alright, now I'm going to mark the V2 lead, which is at the same level as the V1 lead, the 4th intercostal space, but it's going to be on his left side of his sternum. So first we're going to palpate the clavicle and go down to the 4th intercostal space. Mark that. Next we're going to skip to the V4 chest lead. For that you're going to go to the middle of the clavicle, so you're going to find the middle of the clavicle, and that's going to be in the 5th intercostal space. Go down. Next we're going to go to the V3 lead, which is going to be in between the V2 and V3 lead. So that's going to be right in between these 2 markings right here. That's right there. Alright, next we're going to go to the V5 lead, which is going to be in line with the anterior axillary line, which is right in the anterior aspect of the armpit, and the same level as the V4 lead, so in the 5th intercostal space. I'll go here. Finally, we're gonna mark where the V6 lead is going to occur, and that's going to be in the axillary line, mid-axillary line, so the center of his armpit, the same level as V5. Now, once again, placement of this is critical for the ECG recordings to be correct. So don't just eye it up, palpate each anatomical position and place them in the correct spots. Alright, now that each site is marked, now we're going to begin the cleaning process. To do this, we're going to start by getting an alcohol wipe, and we're going to rub down each site. Now, the cleaning process is vital to this working, because if there's not good contact between the electrode and the skin, then the electrode may fall off during the test, which is not what we want. We need to make sure that it stays in contact for good results. So you do not overlook the cleaning process, just to save some time. Alright, once wiped down with the alcohol swab, then we're going to get a gauze pad, and just to dry the area and wipe it additionally. Next, we're going to take in a brazier and rub each site vigorously. Now, I know this may seem excessive, and the skin should turn red or pink. You should rub that hard, but but this is important because good contact is essential for the ECG to work effectively. So just inform the patient they may feel some discomfort. Now that each site is cleaned thoroughly, now we're going to actually place the electrodes. Now placing electrodes, you want to make sure you do not touch the adhesive pad on the electrodes, because this will transfer oils which can affect the ECG recordings and allow the ECG electrode to fall off during the test. So we're going to just place them on the mark spots. Now when placing them, you don't want to put a lot of pressure right in the center. This is because there's a little gel substance in the middle of that, and if you press too hard on that, then it can cause air pockets to form, which can affect the ECG recording. So you just want to place it on, place all around on the outside just to make sure it sticks. Alright, now that we have all the electrodes placed, next we're going to apply the wires to each electrode. Now each wire is labeled to what site you applied to. So this one says right leg. So we're going to apply it there, and just to note, this is the ground lead in the ECG. And this wire says V3, so as you remember, V3 is in between V2 and V4. Alright, and that is how you apply 12-lead ECG. Then you just inform the patient to remain relaxed their entire test. You don't want them to move a lot during the resting test. Obviously, during the exercise test, they will be moving.
Hello, my name's Ari, and I'm going to be walking you through some changes that we would expect to see on an ECG between a resting reading and an exercise reading. So right here we have a depiction of a resting ECG, and there's a couple wave sections that we'll look at, so I'll go ahead and mark them for you. This is our P wave, our Q, R, S, and T, and we'll also be looking at the J point. We'll also be examining changes in the QRS segment, and then also in the S to T segment. Now, some changes that we would see during an exercising ECG. If we look first at the P wave, now this is the atrial depolarization, or the electrical conduction from the SA node to the AV node across the atria. Here we would only see minor changes. If anything, we would see an increase, a small amount in the P wave. Next, we'll look at the Q segment, well, the QRS segment. And in here, we will see some individual changes. Firstly, the amplitude of the Q, R, and S waves will increase. So we'll see a much greater difference. However, in the QRS segment, there will be very, very minimal changes in time. It won't get larger, it won't get smaller, it'll still take about the same time. Next, when we look at the J point depression, the J point depression is the point between ventricular depolarization and the repolarization. And this is usually going to depress, but this is going to blend in with the S and T segment. Because what we're going to see here at the end of ventricular depolarization and the beginning of ventricular repolarization is that it's going to slope upward. So what we'll see is that while this increases in amplitude, it's also going to start to slant. So you're not going to see this definitive line here anymore. And that's what we mean when we say that the J point is going to depress. Then when we look at the T wave, which is the recovery of the ventricles, we have what we can talk about as an absolute versus a relative refractory period. So time can decrease here in the relative refractory period. So time can shorten. And also, we're going to see this wave amplitude increase. So it'll get larger, but it will take less time. Where we will also see time decrease is from the end of the T wave to the beginning of the next P wave. So this will shorten about here before we see going into the next segment. So what does this mean overall? This means that if we cut out some time right here, from one R wave to the next R wave, time is going to decrease. And how do we see that? We see that as an increase in heart rate, or the beats per minute.